A very good morning to each and everyone present in the auditorium. At the outset, let me thank Dr. Srinivas and his team for this invitation for this talk. Over the last 2 days, in these 2 days, we have been seeing great presentations. Yesterday was great, and today we started with a bang. I have been given this topic of pharmacotherapy of vertigo in pregnancy and lactation, motion sickness, Meniere's disease. I distinctly remember an incident way back in the 90s or 80s, somewhere around that. We were attending a Asia-Oceanic meet which was held in Delhi. And me with my seniors, I just passed my MS and I'd gone to attend that conference. After a few presentations, there was a presentation by a gentleman who was supposed to talk on vertigo. Very seniors, like teachers who were sitting with us, immediately got up from the seats, kept on telling each other, अरे चल क्या सुनता है ये लेक्चर के बाद में तुझे तो घर पे जाने के बाद वर्टाइगो को तो स्टेमेटिली देना है तो क्यों देख रहा है. So those were the concepts in the 90s when everyone felt कि vertigo is equal to stemetil, stogeron and all the other drugs which are used for managing vertigo. But then we saw the evolution of neurotology as a science. Professor Albergal gave us an insight into how it has developed over the years into evidence-based medicine today. And that is the reason we see 120 delegates today sitting in this auditorium wanting to know more about vertigo, wanting to know more about how we investigate a patient of vertigo. What we have seen over the years is we have distinct, definite conditions which are responsible for producing vertigo. Friends, vertigo is a symptom which is seen in various conditions of central and peripheral origin. My topic, part of it, yes, today I'm going to discuss about the pharmacotherapy for cases which you'll see in pregnancy and lactation. This is what we everyone know. There are central and vestibular disorders which are responsible for vertigo as a symptom. Few specific central conditions which we all know is migraine-related vertigo, the epileptic vertigo, and multiple sclerosis. What interests us as ENT surgeons is the peripheral vestibular disorders which result in vertigo. The common are the Meniere's disease, the vestibular neuritis, the perineum fistula, BPPV, infective labyrinthitis. The frequency of vertigo being seen in these various conditions, if you just have a look at the line which is drawn, the conditions above almost constitute more than 85%, and that is the frequency of vertigo syndromes. BPPV, vestibular migraine, phobic postural vertigo, central vertigo, Meniere's disease, and vestibular neuritis are the main causes of vertigo. Well, we know specific therapies exist for all of them, and none of them require long-continued, non-specific therapy with anti-vertigo drugs. Our interest, again, the peripheral vestibular disorders. So let us take one each by each. Meniere's disease, vestibular neuritis, infective labyrinthitis, BPPV, perineum fistula, and autoimmune ear disease. Meniere's disease. The drugs which are recommended for management of Meniere's disease are the diuretics like acetazolamide and the combination of triamterene and hydrochlorothiazide. Hydrochlorothiazide can be used alone. There are people who use it alone. The second is the beta-histine. The doses which are recommended vary from person to person and the study to study. Additionally, symptomatic treatment in acute stage, if required, can be given with prochlorperazine, dimenhydrinate, domperidone, metoclopramide, and triflupromazine. Acetazolamide is used with other medicines to reduce edema. This is thinking about endolymphatic eye drops. Acetazolamide belongs to a group of drugs called carbonic anhydrase inhibitors, which help to reduce amount of fluid. Can we use it in pregnancy? Well, the congenital malformation data is highly limited, and although there is no signal that acetazolamide is a major human teratogen, the data is too limited and it should be used only if needed. Lactation, the same applies, it should be used only if needed. Hydrochlorothiazide in pregnancy. Use of thiazide diuretics during pregnancy has been associated with fetal and neonatal electrolyte abnormalities, jaundice, thrombocytopenia, and an increased risk of malformation is associated with them. Hence, the routine use of diuretics during pregnancy is not indicated or recommended. Can it be given in lactation? Well, it is advised to avoid diuretic treatment in lactation. Beta-histine is a strong antagonist of the histamine H3 receptor and a weak agonist of the H1 receptor. It is not recommended in pregnancy and it is classified as category D drug, indicating fetal risk during pregnancy. The same applies for lactation. It is not recommended to be used during lactation. Sinnarizine is an antihistamine and a calcium channel blocker of the diphenyl methylpiperazine group. It is also known to have antihistaminic, antiserotonergic, and antidopaminergic effects, binding to H1 histamine receptors and dopaminergic D2 receptors. The safety of sinnarizine in human pregnancy has not been established. It is not advisable to be administered during pregnancy and lactation. Prochlorperazine is a dopamine receptor antagonist that belongs to the phenothiazines class of antipsychotic agents that are used for antiemetic treatment of nausea and vertigo. It is a highly potent antipsychotic drug. Animal studies have revealed evidence of harmful effects, and there is a possibility of teratogenic effects in humans. There are no controlled data in human pregnancy. Hence, the use is recommended only if clearly needed and the benefit outweighs the risk to the fetus. It can be used in small doses. The dose and duration of the treatment in pregnant patients should be as low and short as possible. Its use is not recommended unless clearly needed during breastfeeding. Phenothiazines have been detected in human breast milk. Dimenhydrinate is a combination of two drugs, diphenhydramine and 8-chlorotheophylline. It is generally considered safe during pregnancy because it is a class B drug and does not have any risk which are found in animal studies. Meclizine is used to treat or prevent nausea and vomiting and dizziness caused by motion sickness. Meclizine is also used to treat symptoms of vertigo, dizziness, or spinning sensation, which is caused by diseases that affect the inner ear. Animal studies have shown cleft palates at 25 to 50 times the human dose. This drug should be used during pregnancy only if clearly needed. Occasional doses of meclizine while breastfeeding are unlikely to cause a problem for your baby. Apart from these, the recommendations for managing Menieres are intratympanic injections of steroids and gentamicin. Well, they can be offered even during pregnancy. Managing vestibular neuritis. The symptomatic treatment for vestibular neuritis can be taken care of with triflupromazine, metoclopramide, and the domperidone to be used as antiemetics. and vestibular sedatives like prochlorperazine and dimenhydrinate are recommended. Managing a vestibular neuritis, prednisolone is generally recommended in the dose of 1 milligram per kg dose, tailed off in 5 days. There are some neurotologists who prefer using acyclovir, 200 milligrams 5 times a day for 7 days. And apart from that, we recommend vestibular rehabilitation exercises. Can these drugs be used in pregnancy? Oral corticosteroids like prednisolone, long-term during pregnancy, have been associated with increased chances of delivering a baby that is premature and or has a low birth weight than expected. Long-term use, hence, is not recommended. Small doses in short term can be given if found necessary. Maternal doses of prednisolone up to 40 milligrams produce low levels in milk and would not be expected to cause any adverse effects in breastfed infants. High dose of steroids are rarely necessary in long term and so can be used in breastfeeding. Acyclovir was found in breast milk. However, the amount seen in milk was considerably less than that is used to treat infants that have been infected with herpes. Acyclovir is safe during pregnancy and breastfeeding. Managing benign paroxysmal positional vertigo. There is absolutely no role of vestibular sedatives in management of BPPV. The recommended protocol is physical therapy and the various maneuvers. So we can manage a patient of BPPV in pregnancy using these maneuvers as and how they are recommended. For perineum fistula and infective labyrinthitis, we have the conservative and the surgical management. The same can be applied during pregnancy. The recommended protocol for phobic postural vertigo is SSRIs, the benzodiazepines, and the counseling. There are several antidepressants that can be used during pregnancy and lactation, but they are with some risk of side effects. However, the risk of medication use must be weighed against the risk of ongoing untreated depression for both mother and child and the risk associated with not breastfeeding. Benzodiazepines should not be routinely prescribed for pregnant women except for the short-term treatment of extreme anxiety and agitation. This is because the risk of the fetus, for example, cleft palate, and the neonate, for example, floppy baby syndrome, consider gradually stopping benzodiazepines in women who are pregnant. The available literature suggests that it is safe to take diazepam during pregnancy, but not during lactation because it can cause lethargy, sedation, and weight loss in infants. Migraine-related vertigo deserves attention because we need to manage it by prophylaxis and during the acute attacks. For prophylaxis, we have been recommending anticonvulsants like divalproex sodium and topiramate, the calcium channel blockers like flunarizine, beta blockers like propranolol, and antidepressants like nortriptyl and imipramine. Divalproex sodium is used to treat certain types of seizures and epilepsy. This medicine is an anticonvulsant that works in the brain tissue to stop seizures and helps prevent migraine attacks. This drug can cause fetal harm when administered to pregnant women. Pregnancy registry data shows maternal valproate use can cause neural tube defects and other structural abnormalities like craniofacial defects, cardiovascular malformations, hypospadias, and lymph formations. Hence, the use in pregnancy is not recommended. Because of the low levels of this drug in breast milk and infant serum, no adverse reactions during breastfeeding have been reported. Theoretically, breastfed infants are at a risk of drug-induced hepatotoxicity. So, if we are giving this drug during lactation, the infant should be monitored for jaundice and other signs of liver damage. So, can be used in lactating mothers if needed. Topiramate is other drug which is used for preventing controlling seizures. This medication is also used to prevent migraine headaches and decrease how often you get them. It is a big no for topiramate during pregnancy because there is a higher risk that your baby will develop a cleft lip or cleft palate. Because topiramate could harm your baby, you should not breastfeed while you are taking topiramate. Propranolol, we know, is used as a beta blocker to treat high blood pressure, irregular heartbeats, and tremors. It is also used to prevent migraine headaches. This medication should not only be used in pregnant women if no other medication can offer the same benefits. Propranolol should not be used during pregnancy unless it is considered very essential. Propranolol passes into the breast milk in small amounts. It is least likely of the beta blockers to have harmful effects on the nursing baby and is one of the preferred drug during breastfeeding if the mother needs it, so can be given. Flunarizine is a drug classified as a calcium channel antagonist and is used to reduce headache frequency. As a precautionary measure, it is preferable to avoid the use of flunarizine during pregnancy and lactation, and hence it is contraindicated. Amitriptyline is used to treat symptoms of depression. Amitriptyline is also a class of medication called tricyclic antidepressants. It works by increasing the amount of certain natural substances in the brain that are needed to maintain mental balance. In the ideal situation, amitriptyline is not generally recommended in pregnancy or while breastfeeding. Amitriptyline and similar antidepressants have been linked with a small risk of problems for the unborn baby if you take them in early or late pregnancy. Women with migraine may be concerned about breastfeeding due to fears of exposing the baby to medication. However, many medications can be safely taken during breastfeeding, including acetaminophen, anti-inflammatory medications such as ibuprofen and naproxen, and sumatriptan. Anti-migraine drugs which are safe during breastfeeding are as follows. Low-dose acetylsalicylic acid, ibuprofen, sumatriptan, metoprolol, propranolol, verapamil, amitriptyline, escitalopram, paroxetine, sertraline, acetaminophen, caffeine, and metoclopramide. Anti-migraine drugs compatible with breastfeeding but warranting caution are diclofenac, ketotifen, naproxen, the newer triptans, topiramate, valproate, venlafaxine, and cyproheptadine. Finally, high-dose acetylsalicylic acid, atenolol, nadolol, cinnarizine, flunarizine, ergotamine, methotrexate, and pitotifen are contraindicated. Managing epileptic vertigo, we need to use carbamazepine, clonazepam, nitrazepam, and sodium valproate. Carbamazepine monotherapy has lowest teratogenicity and is also not associated with an increased risk of developmental delay. Can be given in pregnancy. However, when considering fetal malformations, the most desirable anti-epileptic agents appear to be levetiracetam and probably lamotrigine. The traditional anticonvulsants, such as phenytoin, carbamazepine, and valproic acid, are generally considered safe for use during breastfeeding. However, observation for adverse effects are recommended. Clonazepam and other benzodiazepines have been associated with fetal damage, including congenital malformations when taken by pregnant women in their first trimester. Clonazepam is best avoided in first trimester and probably throughout pregnancy. Benzodiazepines are secreted in breast milk. Mothers who are breastfeeding should not take clonazepam. Coming to the central causes and their management, multiple sclerosis, almost in 50% of patients present with vertigo, and the recommendations are intravenous methylprednisolone and cyclophosphamide. Methylprednisolone given to a pregnant woman if her healthcare provider believes that its benefits to the pregnant woman outweigh any possible risk to the unborn baby. It is not known if prednisolone will harm your unborn baby. You should not take methylprednisolone if you are breastfeeding. It may be excreted in breast milk and harm your nursing child. While cyclophosphamide is absolutely contraindicated in the first trimester of pregnancy, but it has been used in later half of pregnancy in patients with breast cancer. Managing central vertigo, we generally need the help of the neurologist, and all these conditions enlisted can be managed with the help of neurologists and the neurophysicians. Well, no drug is considered 100% safe to use during pregnancy and lactation. Just a glimpse, which can be used during pregnancy and lactation. Migraine-related vertigo, we can use in lactation divalproic sodium and propranolol. And in acute attacks, we can use during lactation acetaminophen, ibuprofen, naproxen. And for prophylaxis, if it is in the later stages of pregnancy, we can use amitriptyline. It's a big no for methylprednisolone, cyclophosphamide for pregnancy and lactation. Acetazolamide can be used in lactation, but not in pregnancy. Beta-histine is a big no. Prochlorperazine, short-term use can be recommended during pregnancy. Dimenhydrinate is a big yes in pregnancy and lactation. And meclizine also can be used in short-term during pregnancy and lactation. Prednisolone in pregnancy is not recommended, but lactation it can be given in short doses. Acyclovir can be given, yes, during pregnancy and lactation. SSRIs can be given pregnancy and lactation. And occasional benzodiazepines can be recommended in pregnancy, but not during lactation. Motion sickness is something which we see in and out every day. It is an unpleasant sensation that occurs when a person is subjected to motion in reality or virtuality. The ancient Greeks and Romans also knew it, and NASA has also taken a note of it. What is the cause? It is basically a sensory conflict during motion. When the eyes see something, the muscles feel something, inner ear senses something else, and these signals are interpreted by the brain, and that leads to confusion. What happens when a person perceives motion sickness? He becomes dizzy, is seen as pale, increased saliva production, generally develops a headache, nausea, and vomiting. Who are at risk for motion sickness? Pregnant women, children, individuals who fear and are anxious of traveling, and individuals with vestibular insult due to various reasons in the past. Can we prevent? Yes, prevention is the best treatment. Generally, we recommend the person to eat less before travel. He should be seated in the front of the vehicle, keep his head on the backrest, look constantly at the horizon, surroundings should be well ventilated. The drugs which are recommended to prevent motion sickness are dimenhydrinate, meclizine, promethazine, diphenhydramine, at least 1 hour before travel. The other terminologies used to mention and are motion sickness are seasickness, travel sickness, space sickness, cyber sickness. Can we prevent motion sickness? Yes, exercises have a great role to play. Yogasanas have proven very beneficial. Yogasanas like Surya Namaskar, Vrukshasana, Veerbhadrasana, Matsyasana, Sarvangasana, and Shirshasana have really helped patients with motion sickness. We have protocols of vestibular rehabilitation exercises, the habituation exercises, the optokinetic stimulation, which also help a lot in patients of motion sickness. There are units which take care of motion sickness, the desensitization machines which are available, but they are present in very few centers. We come to the last part of the presentation, that is pharmacotherapy of Meniere's disease, which interests each and every one of us. It is a disorder of the inner ear which can occur at any age, but usually starts between ages of 20 and 50. It is considered a chronic condition, but various treatments can help relieve symptoms and minimize the long-term impact on your life. The symptoms generally are recurring episodes of vertigo, hearing loss, ringing in the ear, and feeling of fullness in the ear. Various etiopathogenesis are mentioned. The autonomic imbalance, autoimmune disorders, allergy, dietary disorders, vascular irregularities, infection, viral, spirochetal, and others ultimately lead to excessive endolymph production, insufficient endolymph reabsorption, or blocked endolymphatic drainage leading to endolymphatic hydrops. We get the symptoms of vertigo, sensorineural loss, tinnitus, and oral fullness. No cure actually exists for Meniere's disease, but a number of treatments can help reduce the severity and frequency of vertigo episodes. There are no treatments for hearing loss that occurs with Meniere's disease. All the treatments, some conservative, some aggressive, are to stop the spells of vertigo. The recommendations are the first line treatment, the second line treatment, and the third line treatment. The first line treatment include the lifestyle adaptation, cognitive therapy, and medical treatment. The second line treatment includes inserting ventilation tubes, micropressure therapy, intratympanic drug administration, and the surgical treatment is the third line of treatment. My presentation will be dealing only with the medical management of Meniere's disease. Well, the principles are treatment of the attack and treatment of the quiescent phase, that is prevention of acute attacks. The drugs which are generally used in treatment of acute attacks are meclizine, prochlorperazine. Nowadays, there is a combination of cinnarizine plus dimenhydrinate, diazepam, promethazine, steroids, and IV fluid support can be offered if the patient develops dehydration during an acute attack. Treatment of the quiescent phase, or the treatment of the prevention of acute attacks. The medical treatment of Meniere's disease is tailored to each patient. Each patient is different and the treatment differs for each patient. Lifestyle and dietary changes are usually the first step. Avoiding trigger substances like salt, chocolate, caffeine alone may be sufficient. Smoking cessation also is recommended. Dietary management are prescribed to each patient. The pharmacologic therapy includes management with the diuretics, the histamine agonist, the steroids, vestibular suppressants, and aminoglycosides. Diuretics like acetazolamide, hydrochlorothiazide, and triamterene in combination are generally used. They decrease the fluid pressure in the inner ear. Neurootologists who believe that endolymphatic hydrops is caused because of the saturation or collection of endolymphatic fluid believe in use of acetazolamide, the diuretics. These medicines help in preventing attacks, but do not help after the attack is triggered. Although diuretics are often used, their efficacy has not been established with appropriate clinical trials. Loop diuretics are generally not recommended because of their potential for ototoxicity. What we are interested in knowing is the Cochrane reviews about diuretics. Well, there is insufficient good evidence of the effect of diuretics on vertigo, hearing loss, tinnitus, or oral fullness in clearly defined Meniere's disease. This is what has been mentioned in the Cochrane reviews. Hydrochlorothiazide is a thiazide diuretic that helps prevent your body from absorbing too much salt, which can cause fluid retention. Triamterene is a potassium-sparing diuretic that also helps your body from absorbing too much of salts and keeps your potassium levels from getting too low. The recommendations which are given in various trials about use of this combination is generally triamterene 37.5 milligrams and hydrochlorothiazide 25 milligrams tablet. What people have also done is they have used in the initial phases lower doses than what has been mentioned here. Hydrochlorothiazide alone can also be used, and it is generally recommended between the dose of 25 to 100 milligrams orally once or twice a day. I have seen patients being managed even with 12.5 milligrams of hydrochlorothiazide. Recently, I was just getting to know about hydrochlorothiazide, And it has also been seen to cause hearing loss like the loop diuretics. Acetazolamide is used with other medications to reduce edema. It belongs to the group of drugs called carbonic anhydrase inhibitors, which help to reduce amount of fluid. The tablet is available as a 250 milligram tablet. General recommendations are half or a full tablet per day, but then there are situations where you will be needing to give at 2 tablets also in a day, depending on what stage the patient comes to you. There is direct evidence through imaging studies. Severity and others have reported reversal of eye drops following diuretic treatment confirmed by intratympanic gadolinium MRIs. This is an important advance considering the literature that suggests that diuretic treatment is ineffective in Meniere's disease. Various studies have supported the use of diuretics in Meniere's disease. These are the few. The review of literature also shows diuretics are believed to decrease the antilymphatic eye drop pressure and volume by decreasing the overall fluid volume status of the patient. And all classes of diuretics have been hypothecated to affect fluid balance within the inner ear. Diuretics, glycerol, Lasix, urea have also been shown to induce short-term hearing improvement in Meniere's disease, which proves the efficacy of diuretic in reversal of Meniere's disease. 8 studies on experimental animals showed a distinct effect of diuretics morphologically of experimentally induced eye drops. Many papers in medium impact journals have reported a beneficial effect of diuretics in Meniere's disease on vertigo, and all have agreed that there is no significant long-term effect on hearing. The only double-blind, placebo-controlled crossover trials of diuretics, combination of triamterene and hydrochlorothiazide, in Meniere's disease in humans by Van Dicklane and others have confirmed the earlier findings of Klockhoff and showed beneficial effects. In conclusion, diuretics do have a positive role in the management of Meniere's disease that is evidence-based, ethical, and scientifically logical. Salt restriction does not have a proven role in control of Meniere's disease. More clinical use and research needs to be taken up, and the use of diuretics like acetazolamide, furosemide, hydrochlorothiazide, triamterene, spironolactone needs a rethink and a reacceptance for treatment of Meniere's disease. Histamine agonists such as beta-histine are widely used in Europe and South America for the treatment of Meniere's disease. Beta-histine's mechanism of action is increasing circulatory flow to the cochlea striovascularis and through inhibition of vestibular nuclei activity. This agent has not been approved by US FDA. It is not discussed much in United States. The drug beta-histine hydrochloride has been used to reduce frequency and severity of the attacks. While the drug is very acceptable to those who use it, the review of trials did not find enough evidence to show whether it is helpful. Further research is needed. This is mentioned in the Cochrane reviews. Beta-histine should not be used concurrently with antihistamines, as beta-histine is an analog of histamine. Doses generally recommended are mentioned as 24 milligrams 2 times a day. There have been studies where 48 milligrams have been used once a day, and there are studies where 144 milligrams per day have been given maximum in some studies. Vestibular suppressants like dimenhydrinate in the dose of 25 to 50 milligrams, prochlorperazine in the dose of 5 to 10 milligrams, meclizine, promethazine, cinnarizine have a role in controlling acute attacks of Meniere's, but they are not recommended as daily supplementation in prevention. We come across prescriptions from many of our colleagues where drugs like cinnarizine, stemetil, and all these drugs are enlisted in the prescription, and at the bottom there it is written to be consumed for next 2 months. Well, that is not recommended in prevention of attacks. Is there any role of oral steroids in prevention of attacks? Oral steroids, there have been very few studies. I'll just mention a few. Oral steroids have been used for treatment with the belief that inflammation and immunologic factors or a direct effect on the vestibular nucleus may reduce the severity of the spells. The study using 18 weeks of steroid treatment, almost 4 months, reported a 50% improvement in vertigo spell frequency. It was administered in the dose of 0.35 milligrams per kg daily for 18 weeks. Prednisone-treated patients manifested a significant reduction in tinnitus, as was mentioned in the study. Oral steroids for treatment of hearing loss in Meniere's disease was studied by some. How is it done? Diary of symptoms is being mentioned by the patient. Audiogram is done on each visit every 3 months and 6 months. If the hearing loss drops by more than 20 decibels in 2 continuous frequencies, they consider giving oral steroids. They have started prednisolone in dose of 1 to 1.5 milligram per kg per day during 10 days and tapered slowly. Intratympanic drugs administration in Meniere's disease. This was covered very well yesterday by Dr. Sunil. That will ease up my job. Intratympanic steroids, the number and severity of the spells seem to decrease for up to 2 years after use. Some studies. The therapeutic rationale is improvement in Meniere's disease has been hypothesized to occur when hydrops is due to inflammation or autoimmune factors or ischemia as a mechanism of attacks. The same applies when we treat patients of sudden sensorineural hearing loss. Intratympanic treatment in Meniere's disease. It falls in between, like when we treat our patients with conservative treatment, dietary modification and diuretics, and when they fail, the role of intratympanic steroids. Ito was the first to report on the use of intratympanic steroids for the inner ear disease when we treated patients of Meniere's disease in 1991. The first report on the use of intratympanic steroids for sudden sensorineural hearing loss was by Silverstein in 1996. These were the pioneers of intratympanic treatment. Shuknet, John Shea, Beck, Netzelski had used aminoglycosides, and Silverstein also recommended use of steroids. Why intratympanic treatment? Enables to have an advantage of the drug without any systemic side effect. Helps to reach higher inner ear drug concentrations. This minimally invasive technique may be applied as an office procedure. Why intratympanic steroids? Endolymphatic sac immunologically active. The presence of glucocorticoid receptors is in stria vascularis has been shown, and the effect of corticosteroids we know is on inflammation. Different intratympanic treatment methods have been recommended. Transtympanic injection, paracentesis, P tubes, microvic, round window microcatheter. This is the transtympanic or intratympanic method of injecting steroids. Round window microcatheter has been available in US, Europe, and Australia. Silverstein microvic for treatment of inner ear has been seen. This was developed by Herbert Silverstein and used as an alternative to the round window microcatheter. It is cheaper, easy procedure, minimum patient discomfort. Silverstein claims microvic prevents loss of intratympanic drug through the eustachian tube. It is easy to remove and perforation will heal soon. The advantages are enables to observe the round window, control disease of medicine through round window membrane, and there is a continuous drug application. The disadvantages, it is an invasive method. There is a discomfort because of the catheter behind the ear. Drugs which are generally recommended to be used in intratympanic therapy are, which increase the permeability, are histamine, hyaluronic acid, dimethyl sulfoxide. The results which were seen in the intratympanic steroid study was the control of vertigo was better in 10 patients and there was no change. And in hearing, there was no change in hearing. Hearing loss was seen in 5. Hearing gain was seen in 11. Intratympanic steroids for Meniere's disease, dexamethasone 4 milligram per ml for 2 days, followed by weekly intervals, was reported. And 80% success has been reported. Recent research is focused on bioengineered extended release intratympanic drug delivery. Betamethasone-loaded PLGA microspheres can localize drug-loaded microspheres to the round window membrane of mice for greater than 35 days with minimal inflammatory response. Intratympanic gentamicin for the treatment of Meniere's disease. It targets the dark cells and the hairy cells. It reduces the endolymphatic production. Gentamicin is vestibular toxic. 80 to 100% vertigo control with intratympanic application has been reported. Mans Magnuson was the first to report intratympanic gentamicin 30 milligram per ml. It is repeated in 12 hours. Yeah, only 3 periods. Yeah. This is how the drug can be administered. It is a simple, moderately invasive, safe, well-tolerated, controlled destruction is achieved. The drug administration directly and only to the disease ear can be given. Higher drug concentration. There is no systemic side effect. The technique has been mentioned. The precautions are, don't ask the patient not to swallow for half an hour after the injection. Do not blow the nose. No yawning, ear tampering. The efficacy can be evaluated with symptoms being evaluated after the injections. The audiometric data can be seen. WEM, PNG, VNG, and VHIT can be used. There have been a meta-analysis of so many studies. Statistically significant effectiveness on vertigo. No significant difference between different protocols. Statistically significant effectiveness on tinnitus and oral fullness. Negative effects on hearing threshold and discrimination scores are at clinically negligible level. Cochrane database, based on the results of the included studies, intratympanic gentamicin seems to be an effective treatment for the vertigo complaint in Meniere's disease, but carries a small risk of hearing loss. No significant difference between gentamicin and dexamethasone of controlling vertigo. The overall reduction in vertigo attacks in the final 6 months of follow-up compared with the 6 months before treatment was 90% for dexamethasone injection and 87% for gentamicin, far higher than what were expected for spontaneous remissions. That is a big thank you again for having given me a patient listening.